Good evening, everyone. Good evening. And welcome to you all to this very auspicious meeting. This is a joint meeting between the Meg Chi and the Royal College of GPs, the VOT Faculty. Welcome to all of you in person, obviously all of you in line. Please, everybody online, can they make sure they're muted and their video cameras turned off. So I'm very, very delighted to be able to introduce to you our guest speaker today, Professor Kamila Hawthorne, who's come all the way from Cardiff with her husband, Barney, who's a retired consultant gastroenterologist. You probably know that Kamila actually did her GP training here in Nottingham, and in fact was a GP principal until 1991, so she knows the area quite well. And Barney and I were school friends. We went to school to Notts Girls High and Boys High, with the Arboretum in between. Once or twice.
No, don't do that because that will ruin. Just leave that.
I'd like to. There's a couple of housekeeping things. Obviously, if there's a fire alarm, please muster point out of the front door. Muster point is to the left by the cafe. Hopefully, we won't be having any incidents. I'd like to also remind you that today is the Mitchell Memorial Lecture. This is honour of Professor Tony Mitchell, who was the first clinical professor here at the medical school from 1967 to 1990. He did invite his daughter Anne to come and listen to the lecture. She had a prior engagement, but she sent her best wishes to everybody. Absolutely delighted that his legacy lives on, and the lecture is still going. So we've had a few apologies from Julie Rutter and Mitchell, as I've mentioned, and from the Dean of the Medical School, Claire Stewart. Thank you very much. Yes, that's right. Who unfortunately couldn't be here, and Pakula Patel as well, because she's not very well. Moving on swiftly, minutes of the meeting. We had a super meeting last time, a month ago. Professor John Beckett came to talk about Jessie and Florence Boot, and then we had a fabulous panel discussion afterwards with an audience full of professors and deans and academics. It was wonderful, and thank you to Caroline again, as I said previously, for helping to organise all that. The upcoming social events I want to just draw your attention to: 2nd of March, Sunday piano recital at the Theatre Royal. If you'd like to join us, it's very informal. Book your tickets with the concert hall directly, and then we have coffee and cake afterwards. And then Sharon Scriven is very kindly going to lead a willow workshop. I think she's going to make a bird feed or something like that. She has her own small holding and grows her own willow, so it should be good fun. It's £10. Please sign up either on the website, or we've got some booking forms in the lounge, or you can contact Alison, administrator. The only other thing to report is that we had a fabulous Burns evening on the 24th of January. Great fun, hilarious dancing, great speeches and toasts and whiskey drinking, all the rest of it. Thank you very much to Mary and Donald MacArthur for all their hard work in organising. It was fantastic. And we raised £642, yay, which is going to my chosen charity, Doctors in Distress. And talking of that, I went to, just briefly, the week before, I went to see Adam Kay perform at the Theatre Royal. I don't know if anybody else went, but it was fabulous. I had a really good time. It was really funny. But at the end of it, he became actually quite serious, and he talked about the really shocking statistics of suicide amongst doctors and other health professionals. And he talked about the charity Doctors in Distress, because he is one of their ambassadors. And so actually I was able to go back after the show and go and talk to him, which was lovely. And I told him that we, as a society, we were supporting his charity, and he was absolutely delighted. So moving swiftly on, any donations obviously will be gratefully received. Next lecturer is my baby brother, He's going to come and talk to us on the 12th of March. Now, Dave's acting chief executive of Sherwood Forest Hospitals, having been a intensive care consultant at Queen's for a number of years. But he's also the director of the Centre for Perioperative Care, which is a national body. It's a cross-specialty collaboration trying to improve the patient's journey, surgical journey, from right at the beginning shared decision making right to the end. Obviously surgery in the middle, and then right to the end when they recover and integrate it back into the community. So I think hopefully this will be a really interesting subject for all, well, for everybody in primary care and secondary care. That leads me on to Professor Hawthorne, who's going to now talk to us about talking the talk and walking the walk. So thank you very much.
Thank you. Thank you, everyone. It's lovely to see you all. Lots of faces from the past. I call myself a serial monogamist, not because of multiple husbands. I've managed to hang on to one for 40 years. He's starting to tremble a bit, but because I'm now on practice number 5, I only do one practice at a time. But the very first one was in Arnold in Nottingham, where I'd done my last 6 months as a GP trainee. I would say that after a lifetime in general practice, 37 years, I have seen the good, the bad and the ugly. And that practice in Arnold was definitely the best. And I'm very sorry I left it. But unfortunately, I had to follow that same husband when he moved to Manchester as part of his career. But I really do miss Nottingham. And it's just such a pleasure to be invited back. So thank you very, very much. So I think Jane asked me if I would think of something fairly contentious, which is why I've chosen this title, Talking the Talk and Walking the Walk. We've got a new government. Lots of things seem to be changing. Lots of promises are being made. And of course, the question is, can this government deliver? Can it deliver its promises to general practice in particular, but to the NHS and to patients particularly, especially? But I'm going to start with Brendan. And I'm sure many of you will remember him. He didn't always drink, I promise you. He just happened to have a wine bottle in his hand when his photo was taken. Brendan was the senior partner in the practice I was in that became Stenhouse practice. I was actually there when the building was built, in fact. Brendan, I think, is the reason why I am still a GP today. Because at that stage, back in 1987, 1988, I was a very brash young doctor. I'd got lots of degrees and letters after my name. In fact, our son-in-law at his wedding breakfast, when he was giving his speech, he has dyslexia. And he said how difficult it was to handle people who had so many letters after their name. So I thought I was the bee's knees. I thought I knew everything. And I couldn't understand why patients were happy to wait 40 minutes to see this gentleman who appeared very nice, but a bit bumbly and who talked a lot. And I just didn't understand it, until one day I actually bumped into him in Sainsbury's car park in Arnold. And I stopped to talk to him because, of course, everybody would. And while I was there, it took about 20 minutes, groups of people wandered past on their way in or out of Sainsbury's, and they all stopped and they all said hello, and they all talked to him about something. Nobody asked him anything medical. And then they moved on again. And I watched this happening, and I thought to myself, this is what I want to, a bit like Baloo the bear. I want to be like you, here was somebody who was a very valued member of his community, who loved them and they loved him. And he'd spent his life serving that community. And he'd done it really well, as you could tell from the way that the patients spoke to him. And I thought, this is, of course, I'm never going to be like Brendan, but I've done my best in the practices that I've been working in. And he's always been an inspiration. Although we left quite soon after in 1991, we kept in touch. And every time I came back to Nottingham, because Barney's got a family here in Nottingham, we would go to see him for a top-up, if you like. And when he passed away in 2011, it was round about the Christmas time. And it was slightly spooky, actually, because his daughter rang me to tell me that he'd passed. And the very next day, I received his Christmas card in very spidery black ink writing, for those of you who remember his writing, in which, because he was always fond of a little joke, he was 91 at the time, he called himself his wife's toy boy because she was 94 and he was 91. So he's an absolutely delightful man. Anyway, back to business then. So, well, how will the new government deliver its promise to save the NHS as it says it's going to do? Well, where are we now? I'm sure all of you will know quite a lot of what I'm going to say here, but maybe I've got a bit more detail than you may have been looking out for. So we had the Darcy report a few months ago. You know, for us in general practice, we were really quite worried over the summer. I went to 2 of the Darcy meetings and general practice wasn't mentioned at all. There were lots of data posters on the wall. We were asked to go around and make comments on these data posters. There was no data on primary care at all. And in fact, I was starting to get really a little bit hysterical in saying to whoever would listen, where is general practice? Who's thinking about general practice? But in fact, actually, there's quite a lot about general practice in the Darcy report. And amongst other things, he said something that really impressed me. He said that general practice, he felt, was one of the few parts of the NHS that was economically sound, was cost effective, and was innovative. I thought that was great that he said that, although he clearly hadn't asked me about any of this because he'd said it all on his own. But what he also said was that the NHS is in a critical condition, but its vital signs are strong. So we then go into a public consultation, which is still ongoing at the moment. There are various groups set up, 4 vision groups, 7 enabler groups. There have been almost 1.5 million visits to the online portal. So if you haven't visited, please do. About 90,000 submissions. In the beginning, some of them suggested things like, we really ought to wrap West Streeting up in a rug and throw them in the Thames. But actually, quite a lot of the submissions have come back with some really interesting ideas. And there have been a number of public events. We haven't yet got a clear idea as to what's going to come out the other end in the 10-year health plan, which we'll publish probably in May, possibly June of this year. It seems to slip a bit in time. But what we are being told is that both the public and NHS staff who've contributed to this have significant pride in the NHS. But they're frustrated that the NHS isn't getting the basics right in terms of access, consistency in care, and the pressure on staff affecting their well-being is all being brought to the fore. So the 10-year health plan is due to publish in late spring. There'll be a comprehensive spending review round about the same time to outline the DHSC budget, so we're waiting on that as well. And the long-term workforce plan is going to be reviewed in the summer at some stage. We don't know about the exact dates of this, but underlying it all is the new government's promise or plan that services should shift from secondary care to primary care to the community. There should be a shift from analogue to digital and from sickness to prevention. And for those of us, certainly in general practice, this is music to our ears, so long as it's properly resourced, and it allows us to practice as GPs in the way we've been trained to do. The long-term workforce plan, again, that was first published 2 years ago now, a year and a half ago. And at the time, I was a fairly new chair of council at that stage. About 2 days before it was published, we weren't allowed to have any input into it. About 2 days before it was published, they sent it round to us. Well, they contacted me and they said, can we have a positive comment on the long-term workforce plan? And I said, can I read it? And they said, no. And I said, well, no comment. So they did send it. And they had promised me beforehand, they said, every time I got worried about it, they said, look, don't worry, Kamila, general practice is got a special mention. And sure enough, when we did come to read it, it did have a special mention. It talked about increasing the number of trainees by 50%, as well as doubling the number of medical students. But when the audit office came to have a look at it a few months later, they interviewed me at the time. And they said, do you realise that when you actually look at the data and you look at the tables at the back, which we'd had some idea of, but I don't think we'd got the maths completely straight in our heads. Do you realise that the numbers of GPs will rise by 4% by 2036, but the numbers of hospital consultants will rise by 49%? And we said, oh, how does that work? 2 and 2 doesn't seem to equal 4 here. And so we have been lobbying ever since then to get that long-term workforce plan reviewed, and we are absolutely delighted that it is going to be reviewed, but of course it needs to be reviewed in the right way, with the right ideas behind it. The reason for it being only 4% increase appears to be not because it's not recruiting more GPs, but it's really not bothering to retain them at all. There's almost no emphasis on retention. And so that's also something that we're really pushing on at the moment as a college. Excuse me, sorry, I'm just getting over a cold. So how will the government achieve its goals? So this is from the Wes Streeting's speech to NHS providers in November. He's talking about a shift of power from the NHS to ICBs, providers and patients. So it's a triple shift. He's telling NHS England it has to reduce its payroll and expenses. He wants more doers and fewer checkers. He wants trust providers to have more freedom and flexibility to innovate, to run community services and manage their own house to meet the needs of patients. I'm just going to have one of these, I'm really sorry. And he wants those ICBs that perform the best to have greater freedom and flexibility on how they spend their capital, greater share of capital allocations, and zero tolerance for failing systems. Really interesting way of looking at things. He's told ICBs that they must now focus on learning about their communities they serve, and focus on local commissioning, learning what communities need to develop this new neighbourhood health service that he's talking about, which I'll talk about a little bit more later. The explicit aim is to keep patients out of hospital with care closer to home and actually in the home. It is a real worry because the NHS has missed its targets since 2015. So we're talking about 10 years of missed targets. A&E waits more than 12 hours are causing thousands of avoidable deaths. Again, the National Audit Office has just recently published on this. The Royal College of Emergency Medicine had worked out that there were more deaths for longer waits in A&E, but had no idea that it was actually 3 times as much as what they'd been calculating. We've got 345,000 waiting for mental health at the moment, which is the population of Leicester. And the health of the nation is really dropping. We're seeing a levelling off in healthy life expectancy, particularly in people who live in deprived areas. It is really quite heartbreaking to see. So just continuing on with the speech to NHS providers, the elective recovery plan was announced then, and it came out in early January 2025. The aim, of course, is to reduce the waiting lists for elective procedures. As previously, it was launched in haste, almost no consultation with Royal Colleges at all. And those of you who may have read it when it first appeared would have noticed that it had a really interesting case study in it. The case of Sarah. Sarah was in her 30s. Sarah had symptoms of what sounds a bit like sinusitis. So she went to her GP practice where she saw, so this was supposed to be an idealized case of the future of the NHS with the way that AI and better diagnostic services would work for patients. So Sarah goes to see her GP practice where she sees a nurse practitioner who's worried about her and organises a CT scan. of her sinuses, is then discussed with an ENT registrar. This is the case study, who organises an MRI scan, decides that Sarah needs a nasal spray, and 2 weeks later, at review, I know, I couldn't believe it when we read this. 2 weeks later at review, Sarah's better. So we read this in horror, absolute horror, and said, well, where's the GP in all of it? You know, what the hell's going on? And I'm now quite friendly with Claire Fuller, who's head of primary care in the NHS. And I texted her first and then rang her and said, Claire, what is going on here? And Claire said, I know, I can't believe it. We weren't asked about this case study. Nobody showed it to us. It was written by the people who wrote the elective recovery plan, and they didn't ask a primary care person at all to write this. So, of course, there was a lot more lobbying and jumping up and down. And, of course, Twitter had gone mad by this stage. X had gone mad by this stage. And in the end, they took down the case study. So the case study disappeared. But it just gives you an idea of how government and DHSC don't communicate well with each other, and they don't work well with each other. The other thing that Wes is talking about is fewer targets, that prioritising, because we can't do everything. So there's been a planning guidance paper last week to reduce the number of targets, and it's concentrating on urgent and emergency care when people need it, improving GP access, we've heard that one for a long time, and reducing waiting times to an 18-week standard. Alongside that, he's also announced at our October RCGP conference of what he called the red tape challenge, which is to try and reduce bureaucracy in the system, both in secondary care and in primary care. Data handling and integration of health records. And of course, the independent commission led by Baroness Louise Casey to look at social care. And again, there's been a lot of conversation about this because it looks as if it may not pronounce until 2028. He's also talking now about these neighbourhood health services and saying that this is what ICB should be focusing on. What will they look like? We don't really know yet. But this is going to need an awful lot of leadership and strategic thinking. So these are the things then that Wes Streeting has been saying. As we will bring back the family doctor, we'll have a neighbourhood health service, we'll halve the difference in healthy life expectancy between rich and poor. They have written a children's health plan, focus on prevention, going to solve social care, and then the three themes that I'd mentioned, secondary to primary, sickness to prevention, and analogue to digital. What does this all mean? And at what cost? You know, it was very different when Tony and I qualified as GPs here in Nottingham. I was 1988. Were you 1988 as well, Tony, or were you younger than me? In those days, we had 24/7 responsibility for patients, 6-minute appointments. In fact, when the appointment length went up from 6 minutes to 10 minutes, by then I was a GP in Cardiff, I remember some of my partners saying, what are we going to talk to patients about? Honestly, how can it possibly go up to 10 minutes? You know, it was just very different. We did a lot more hours, but there was less we could do for patients. So if somebody had back pain, I don't know if you remember this, we put them to bed for 6 weeks. Somebody had a stroke, guess what? Put them to bed for 6 weeks. And if somebody had an MI, you've got it. We put them to bed for 6 weeks as well, because we just didn't have the things that we do now that have improved life expectancy, have improved quality of life. Medicine has really advanced massively in the time that I've been a GP. It's really quite phenomenal. So there's an awful lot more we can do. And of course, as a result, patients living longer, they're much more complex. They have multiple chronic illnesses. All their medicines interact with each other. It's assuming that they're taking them in the way that you hope that they are. And all their blood results sometimes go quite crazy. So it is a much more complex job to the one that I was doing back in 1988. And I will always remember when our daughter was about 3, at that stage we were living in Manchester, going into her bedroom on a Saturday and saying to her, Rahana, you need to tidy your bedroom. And she looked at me up from the floor and said, "Mummy, don't bother me now. I'm busy. I'm on call." And I thought, oh dear, oh dear, oh dear, because I knew who it had come from. It had come from me, because Barney's on call was in hospital. It wasn't at home, so she wouldn't have heard him say that. You know, so it was affecting our families. It's affecting, you know, the whole way in which we lived, really. So we need to have a think about what's this family doctor that we want to bring back. Do we want to bring back the doctor of the 20th century, or do we need a family doctor for the 21st century? So I'm just going to show you a couple of slides as to, you know, where we are. And this one is from the King's Fund last year, February. And what it shows on the top left is the quantity of GP appointments daily. So you'll see it's 876,164. That was a year ago, so it's probably more by now. But then also the outpatient attendances, the community health, A&E, inpatient stays, etc. And you can see that the bulk of the work of the NHS is being done in primary care. But then when you look at the figure 2 below, you'll see that the funding expenditure is much higher for the acute trusts at the right-hand side, and primary care is this one here. So the reality is quite a long way from the vision of the health and care services that's focused on communities rather than hospitals. It's not, the financial and workforce growth is not aligned to this vision either. And there are urgent problems constantly take priority over longer term issues. Currently, the budget of the NHS that's spent on primary care is about 7.4%. 10, 12 years ago, it was 11%. We're lobbying for a need for at least taking it back up, however gradually, to 11%. But I would argue that perhaps it needs to be more than that to be able to do what the government wants us to do. And that is what we're saying to government at the moment, is that, you know, we cannot do these things unless we get resourced appropriately to do them. So here I've got an article from NHS Confederation that was in August 23. This is an interesting one. What this one did was compared spending in primary, community and acute care between 2015 and 2019. And it compared those people who'd spent the least, those trusts that had spent the least, with those who had spent the most in community care. And what it found was that every pound spent on primary or community care could have increased local economic output by £14. And the additional economic growth created would have returned more back into the national NHS budget, paying for itself. I think really interesting. And this is about increasing the local economic output. This is not just about what you save in the NHS from prevention. I think it's a really interesting paper. So let's look at now then. I'm sorry that it's so GP focused, but I suppose my head is very much in GP land. We are finally seeing GP numbers rising slowly. When I first became chair a couple of years ago, we were about 1,000 full-time equivalent GPs below the number that we had in 2018. And it has been slowly rising ever since. But now we've got unemployed GPs needing thousands more, despite needing thousands more to staff the service. GP practices in England are handing back their contracts. They're certainly doing so in Wales as well, where I'm working now. And when I first qualified in 1988, it was approximately 1,600 to 1,800 patients per full-time equivalent, and now it's 2,300. Of course, that affects the quality of care that we can offer our patients, who are increasingly complex, getting older, with multiple chronic illnesses. And compared with affluent areas, we're seeing that GPs in deprived areas earn less, but look after more patients with more illness. That's a Health Foundation finding. And then on the right-hand side is our tracking survey from 2022. You'll not be surprised to see that how many GPs plan to leave the service within 5 years. They're feeling that they're at very high risk of burnout. They fear patient safety is being compromised with the way that they're being asked to work, and they're citing stress, working hours, and lack of job satisfaction. I think this is all causing really significant moral distress. especially as patients are bringing complex and intractable problems to GP practices, and the system is crumbling. You know, when you try to use the system to help people, it doesn't work so well. And it's reflected in patient satisfaction surveys. This is from The Economist. And there's really, as you can see, a huge downturn in patient satisfaction. A lot of it from general practice is to do with satisfaction with access to GP practices. When I first started as chair of council, I was told, well, I can never get an appointment with my GP. You're all out there playing golf, aren't you? Now what they're saying, so maybe I've been a little bit successful, is they say, I can never get an appointment with my GP, but I know how busy you are. So maybe that's a bit of a help. And there's a slight ray of hope in that I was told by Amanda Doyle from Primary Care and NHSE last week only that their internal satisfaction surveys that they do of the public were at 60% on GP access last July, and they're now 71% as of last week. So maybe we're on and up again. And the message from Amanda is keep doing what you're doing, because it seems to be helping and working. But of course, it's not just us in the UK. So this is a Health Foundation report of 9,500 primary care physicians in 10 high-income countries. And there's really high pressure on GPs everywhere around the world, all complaining of higher workloads, stress, signs of emotional distress, believing that the quality of care has worsened since the pandemic. We feature second from the top. So if you are planning to leave the country, don't go to Germany, because that's the worst. But it's about work-life balance, time with patients, and many planning to stop seeing patients in the next few years. And certainly most of the GPs who are of my age cohort have either left practice or are seriously considering it very soon. There is a ray of light, there are silver linings to all of this. They did find that UK GPs have some very special core strengths that others perhaps are not quite so well prepared for. We do manage care in complex patients really well, and our approach to holistic care is really well advanced. So that's good to know. So let's look at our assets. Where are we heading? So we know the population is aging. We know about climate change affecting health. We know that the NHS capacity is unable to service public demand. There will be future pandemics. We don't quite know what it will be yet, but I'm sure there will be something. And we know that chronic disease prevalence is rising due to all sorts of factors, not just due to aging. And we know that social inequalities feed health inequalities, and that the gap between the rich and the poor is widening. And we also know that in general practice, the people that we see, only about 17% of them are presenting to us with true biomedical causes. There are so many other factors, and the GPs in the audience will know all of them. Having said that, there are some great advances in medicine. Genomics, advances in technology, medical technology and AI, new drugs, new ways to manage common illnesses, new vaccinations, all sorts of announcements all the time on new ways of diagnosing and treating cancers. So, and of course, we live in a highly connected set of communities now. The only problem is, we have the technology, but it doesn't seem to be in the NHS at the moment. And without that analog digital shift that Wes Streeting's talking about, it won't work. None of what they want to do will work unless we can actually share data, have integrated care systems, communicate better, and use our technology better. And this is an example of the sort of thing that's possible at the moment, but it's only happening in Frimley ICS and to a little bit in LLR, which is the Leicestershire ICS. But what they've done in Frimley is they are able to use big data to understand their cohorts with unmet needs, then to case find and identify them for proactive direct care, proactively support them, and then evaluate what they're doing so that what they're doing continues to be evidence-based. So it is, there are some really exciting opportunities if we can only use our data well. And we have got the most valuable data perhaps in the world, because it's all collected within the NHS. It's just not speaking to each other at the moment. This is a slide from the Health Creation Alliance. And this is about why communities matter for health and the need to see it with communities at the heart of public health in terms of reducing health inequalities, engaging those most at risk of poor health, empowering people to have a better say in their lives and in their health, and having more connected, resilient, cohesive communities. I always remember reading a paper by David Fone, public health physician from the Cardiff area, based on the 1,000 Lives studies that were done in Caerphilly. This is from about 10 or 15 years ago, but it really struck me at the time. So perhaps not surprisingly, what he found was that in more deprived areas, there was a higher prevalence of mental health problems, but that was partially mitigated by having cohesive communities compared to communities that were disruptive and not able to talk to each other. And this is what we need to be trying to do much more of. And really all I want you to take from this slide, which is from the National Association of Primary Care, is that the community is at the centre of this map. And then round it is where we belong, in the yellow bits in general practice, but together with community pharmacy, nursing, social care, optometry, dental, mental health, social prescribing, health visitors, public health, and then beyond that, then the more specialist services. And that's really the model, I think, that is probably going to come out in the health plan in a few months' time for neighbourhood health services. So what does a modern practice look like today? So this is my practice actually in Mountain Ash. So if you don't know where Mountain Ash is, it's very beautiful. Please come and visit me. It's about 18 miles north of Cardiff. If you travel north up the A470 towards Merthyr, and about halfway up there, take a left towards Aberdare, and Mountain Ash is just there. It isn't a mountain, of course, but it is very hilly. And certainly when it snows or if it's very frosty, you really have to beware both your car brakes and your heels. But here we are, beautiful modern building, very purpose-built. We have the primary healthcare team co-located with us, just as we used to in the old days. We are a training and a teaching practice. We're very active participants in our cluster because we don't have PCNs and ICBs in Wales. We also have a local community hospital diagnostic hub and treatment hub not very far away, probably less than a mile away. So we have all the things that people keep telling me we need to have in a much more standardized way across the country. But we're on the knife edge of survival. Partners have thought several times of handing back their contracts. They can't carry on. And the reason is that we can't attract GPs to come and work up there, certainly not as partners. More recently, we've been able to attract salaried doctors, but not as partners. And of course, what we're seeing is the number of salaried doctors is going up while the number of partners is coming down. And eventually, we're going to get to a point where there won't be enough partners to sustain the whole network. And in order to deal with this, really, we need a contract that changes our GP core funding, which is going to be the work of the GPC and government in the year or two to come. We need to reduce bureaucracy so that there's less red tape. We need to reduce the financial risk that partners feel, and which is why a lot of youngsters don't want to take on practices. And we need the ability to flex to the needs of our community, which in a way that we can't do at the moment. As a college, we've been working on this for many years, actually. This is our Fit for the Future that was first published in 2019 under one of my predecessors, Helen Stokes-Lampard. And we've been updating it, and you don't have to go through it in detail, but essentially it's aiming for a revitalised profession, multidisciplinary practice teams, doctor-patient relationships, and continuity of care, and collaborating at scale. And so one of the things that I've done since becoming chair, so this was in the summer of 2023, being aware that there was a general election coming, we sat down to write our manifesto. Now, I've never written a manifesto before. Has anybody here written one ever? I've never done one. So what do? Well, you look at what your predecessors have written. So I found a few and had a look at them. And they all seem to follow a very similar format. They asked for 5 to 7 things. There was a little introduction. It's kept very simple. It could be made into a leaflet so you can hand them out easily. So I followed that format, and then I thought to myself, okay, these are the 7 things. So we're calling it the 7 steps to save general practice and safeguard our NHS. So once I'd got there, I thought to myself, okay, well, what about those earlier manifestos? How many of the things they asked for did they actually get? So I went back and had a look over the last 10, 15 years, and on average, they get 2. So I've had a look at these 7 and thought, well, which 2 am I going to get from these 2? You'll have to have a think yourself as to what you think. Actually, at the moment, certainly from the verbal promises, it's not been delivered yet, I think we might have 4. So increasing resources to primary care is certainly being talked about. The red tape challenge to reduce bureaucracy, improving infrastructure, and review of the long-term workforce plan with a focus on retention. So, that would be amazing if we get that far. But it's an interesting business trying to be an influencer. What I've discovered is that if you are too challenging, they go away and they don't want to talk to you anymore. They don't listen anymore. If you're not challenging enough because you want to be inside the tent, they just walk all over you. They ask you for positive comments on things you haven't read and that sort of thing. Or they write stupid case studies about Sarah. So, it's about getting that right balance. I'm not sure if I've got the right balance. You will have to be the judge of that. But it's about being willing to stand up and say, I'm not happy with this, when you're not happy with something, and knowing when to stay stumm, when actually there's no need to say something because it's so obvious. So when we published that manifesto, I'm sorry, a couple of people have heard this story already. When we published this manifesto, it was in the October 2023 annual conference in Glasgow. And we did what they'd done to us. We sent it to them a few days before out of courtesy. And I talked about this in my speech, my big plenary conference speech on the Thursday morning. By the time I'd finished the speech at coffee time and went back to the green room, the policy and press team were actually quite agitated because they said that the Labour Party had been in touch. They were furious. They didn't like the manifesto. They didn't like the speech. They didn't like what I said. And Wes Streeting was writing an opinion editorial in the Times that would come out the following day, slamming the whole thing. We'd had a meeting set up with them for the following Wednesday, which he'd already cancelled. And I remember sort of thinking, I'm really quite anxious about this. I'm really quite scared, because this guy is almost certainly going to be the health secretary. And I've clearly offended him greatly. Anyway, there wasn't much I could do about it. And promptly, of course, at 1 minute past midnight on the Friday morning, my phone starts pinging because those of the conference attendees who are still awake have seen it because it's appeared in the Times and they feel like I need to know about it, so they send it to me. And sure enough, he was furious. 2 things he was angry about. The first was that I had asked for at least 2 billion in infrastructure. That's number 5. How dare she ask for money? We're not, we haven't got a blank checkbook. And then the second thing he was cross about was that in my speech, and it was true at the time, I said that the Labour and Conservative parties, the 2 major political parties, didn't have a coherent primary care policy. And how dare she do this? How dare she, put us in the same bracket as the Tories? So, of course, I thought to myself, oh, goodness, now what's going to happen? Tried texting him. I tried ringing him. I tried emailing him. Got absolutely nothing. And about 3 weeks later, I was at another conference, this time in Liverpool, and was going up the escalator. I was speaking, and he was speaking just ahead of me. So he was actually 3 steps above me on the escalator and avoiding eye contact. And so in the end, I thought, I can't bear this. So I looked up at him and said, Wes, are you speaking to me? And he said, well, yes, of course I am. And so he took me off into a corner and was terribly nice. And then about a month later, I was at another Labour Party do, this time in Manchester, standing there in a crowd of about 300 people with my little glass of wine, thinking, why have I come here? I can't see anything. I'm just way too short. This is just a mistake. Anyway, he breezed into my bit of the room, took one look around. Maybe I was the only person he recognised, but anyway, he came up and gave me a great big hug. And I'm afraid we've been like that ever since. So that's certainly brought me to his attention. So what do today's GPs want? I think they're bright. They've got ideas and vision for general practice in their patients. I'm just blown over by all the innovative things that different GPs do. It's just amazing. And that's just a list of some of them. I think they're entrepreneurial and they're really innovative. What do they want, though? They want to be valued, don't we all? They want to have time to do their job properly. They want to see patients. They want to be paid appropriately. And they want a reasonable work-life balance. I wouldn't want my children to go through what I had to. They don't want the hours we worked 30 years ago. They don't want the responsibility for keeping a practice afloat. They don't want the financial risk of being a partner in the current model. That's got to change. They don't want the bureaucracy, and they certainly don't want to be replaced by other doctors or, in this case, physician associates who behave and do what they're supposed to be doing. And they've made that very, very clear. So the government's 10-year health plan must be for 10 years. We've got to stop planning for the next 3 years. We need to prioritise what's needed because we can't do everything. We need to focus on diagnostics, prevention and treatment and be fully resourced. We need to learn from the best in other healthcare systems. We need to prepare for normal times rather than always working in a crisis. We need to cover the whole life course, focusing on population needs and parity of esteem for mental and physical health. We need a cross-government approach to tackling social determinants of healthcare, because unless we do that, we're just tinkering around the edges, trying to reduce that poverty gap. And we need to join up health and social care, embed equity, diversity and inclusion, joined up data systems, you can see it, and that's really just for starters. And we need to support local leaders and clinicians to transform care and support staff well-being. So how can we as a college help the new government? Well, by keeping the ideas for improvement and change coming and by continuing to lobby in the way, as I've said, not too challenging, but challenging enough to keep them awake. And if any of you have got ideas that you'd like to pass on to me, please do, because one brain is just not enough for all of this. And I do have lots of brains helping me, actually. I have the most wonderful policy team in the college. My officers are fantastic. Our council is fantastic. Those of you who are GPs, if you'd like to come and observe a council meeting, please get in touch with me and come and observe and see what you think of the things that we are talking about. We need to keep the channels of communication open. Often informal conversations help. I've been surprised by how often an informal dinner can help actually with relationships, because I didn't really like that sort of thing before I started this job, but I'm getting used to it now. Open and private letters to key stakeholders, letters that we tell people we've written, but we don't actually show them, and some of them we publish. Releasing reports on key issues, surveying our members to provide us with data so that we can use it, and engagement through events and conferences. And we want to work with them. We don't want to just seed them with ideas, but they seem strangely reluctant to let us work with them. So Julian Tudor-Hart, I'm nearly finished, was a GP just outside Swansea. I had the pleasure of meeting him a few times. He's quite a scary character, actually. And of course, he's famous for the inverse care law. But actually, what I really like are the 3 principles below this. He said that medicine without a theory of justice is no medicine at all, that the health of individuals cannot be separated from the health of societies and the values underpinning those societies. And then he said, research matters, not only because it delivers reliable knowledge, but also because it can be a powerful political instrument for social action. I wonder what Aneurin Bevan would say of the NHS today. He was a great believer in disruptive leadership. I think there's going to be quite a lot of disruption in the health service if this government manages to do things the way it wants to. Whether or not its financial situation will allow it is another matter altogether. I think what I quite like about Aneurin Bevan, apparently, he was very didactic in the way he said things. Things were very black and white with him. And he said he really didn't like people who walked in the middle of the road because they tended to get run over. So being a doctor can be so rewarding. But in the last 10 years, I think it's become increasingly tougher, and we do need to think about how we do things differently. Because if you always do what you always done, you always get what you always got, and we can't be doing with that anymore. So I think it will be difficult to walk the walk, but we all need to pitch in, and we need to keep guiding, and we need to be critical friends and try and help this government achieve what it says it wants to do. Thank you.
Thank you very much, Kamila, indeed. Have we got some questions from the audience? Jonathan, I think actually we got a mic. Would you mind, Jonathan, would you mind taking the mic?
You said two things that struck me superficially would be contradictory. One is training GPs who can't find jobs, and one is we have practices that can't find GPs. One of the things we find with our residents is that attitudes have changed, and geography and where you want to live is now more important than what you want to do. And generally, the areas that need doctors are the areas where people don't want to live. So how do you, if you're going to address health inequalities, you're going to have to work out a way in which the GPs in the more deprived areas become attractive to people. How can you do that?
So I think we need to be thinking about the way in which we retain our newly qualified GPs. What we're finding is that people are leaving the profession at all stages of their career. So we're losing them newly qualified, mid-career, as well as, early, late career. Everybody is going to need different incentives, if you like, to stay in work. And I think, so what happened with the, in England, is that we'd been asking for some time, as had the BMA, for the ARRS scheme, the additional role scheme, to be opened up for GPs so that we could get GPs into practices better. The previous government said, no, they're not additional roles, they're key roles, so they're not additional, they don't belong in there. So they wouldn't do it. However, Wes Streeting changed that. And much to our surprise, he not only opened it up to GPs, he found about 86 million for the jobs that he keeps talking about. So we were delighted when we heard that. We thought, he's wringing blood out of a stone, really. It really is like that, getting money out of the Treasury. And it helps that he used to work in the Treasury, so he clearly has friends there. And we went to see him last July and said, what you need to do now is to make these jobs so attractive that everybody wants them. And we've got some ideas. We've got a list of things that you could do, wouldn't cost you that much, a little bit maybe, but you need to price it right. You need to provide mentorship, because these are newly qualified GPs. You need to stick them in one practice so that they can get their feet under the table and learn about the joy of general practice and the continuity of care. And you need to give them some protected time to develop themselves so that they can develop extended roles if they want to. So you listen to all of that. He agreed with all of it, actually. He wanted his scheme, he'd sweated blood to get it. He wanted it to work. And so said to NHS England, come on then, you work with RCGP and off you go. And he went off into the sunset thinking, job done. Of course, what happened was that NHS England didn't contact us. We waited weeks, and in the end, I contacted them. And what I was told, because the other thing we'd said is put these jobs in underserved areas, so that people, would want the jobs and they'll go there. Because, in our time, we followed jobs. That's partly why I've moved around such a lot. But this generation are not keen on doing that. It's true. And we need to listen to them. I don't think we just ignore them and say, whatever. Anyway, what I was told was, no, our job is done as NHS England. Our job is just to put the jobs out there. It's up to the PCNs to advertise them, and it's one per PCN uniformly across the country. What do you do? I was furious, actually, because I thought the Secretary of State had said, do it, and then they didn't. So I did something that I think is probably quite wicked. I went to see Stephen Kinnock, and first of all caught up with him at a launch, and said, do you mind if I come and talk to you for a coffee, and I don't want NHS England in the room. And I don't think that's quite normal for a Royal College chair to speak that way, or president to speak that way. But anyway, much to my surprise, he agreed. And so we did have that meeting, and I told him what I thought. I told him why I thought things were not as good as they should be. And he turned to me and he said, oh, now what do we do? And with absolute deadpan face, I didn't look as if he was joking. He said, shall we sack them all? And of course, I sat there and I thought, yeah. But no, my head of policy was there. And of course, he stepped in and me, oh, no, that's not what we mean at all. Well, I was thinking, come on, it's time for a verbal warning at least. But I think the message has got in there. And certainly the Public Accounts Committee has written a very damning report about NHS England as being unimaginative. And that was then taken up by the Health Select Committee only a week or so ago. And they've also said pretty much the same thing. I don't know where this is all going to end up. But what I said to Stephen Kinnock is I think that NHS England has got a blind spot when it comes to general practice. The number of times I've been to meetings that I've been personally invited to, but when I get there, there isn't any general practice on the agenda at all. It's just missing completely. And of course, this whole case of Sarah that we were talking about and laughing about earlier is another sign of that. So I hope that the message is sinking in terms of what we've got, this paradox, that we've got unemployed GPs and yet we desperately need them. If you just look at, we've got 2,300 patients per full-time equivalent compared to 1,800, just to get back to the 1,800 so that we can offer the continuity of care, you're going to need at least 6,000 full-time equivalent GPs more. So we've got GPs who are unemployed, we should be using them, absolutely. I hope that they will find a way of getting that through. At the moment, I think practices have been so chronically underfunded, they can't afford to pay, in our practice in Mountain Ash, we definitely need one full-time equivalent GP more, and they can't afford it. And then when the National Insurance Employers Contribution thing came through a few months ago, they said, well, that's completely put paid to, we just couldn't do that at all. So yes, it's difficult. You kind of feel like one step forward, one step back all the time.
Got the mic.
Yeah, that's right.
Hi, Kamila, thank you for that. The Australian government are very keen to get UK doctors over to Australia to work in their remote and rural areas. We've been very, I'm a radiologist, and we've been very concerned that they're going to recognise our qualifications in Australia. One of the things that put people off going to Australia as more senior doctors is they'd have to take the exam again. And I believe that last year they started to recognise the GP qualification. Have you noticed a big effect from that?
So we've tried searching for some data on this. We've tried asking the GMC if they can tell us about the letters that they're supposed to be writing for people who want to go abroad, sort of letters of competence. And they tell us that there are no more letters being written than there have been in previous years. So it is really difficult to winkle it all out. But I think a lot of people do go to Australia. Quite a lot come back. But they don't all come back. I completely agree. And it is a real worry, especially since Australia is doing some really interesting. So when we were in Australia on holiday a few years ago, it was actually on the side of buses going past and come and be a GP. In Australia, it was saying that. At our last conference, I must say I was pretty miffed because an international member from Australia had come to Liverpool and was advertising free drinks to talk about jobs in Australia. So that was what was going. No, we didn't. I actually wanted to go and get a free drink, actually. But my team wouldn't let me. They felt that it wouldn't, because I wanted to tell him what I thought of him. But no, they wouldn't let me go because they felt it wouldn't look good.
Can I butt in? There's another problem with this. My daughter's moved out to New Zealand to work as a medic out there.
Oh, for the audience that's not in the room.
Do we still have time for mic? Oh, yeah, I think they can hear from mine, can they?
Do you want to go back to there? See if you can better.
It's not just Australia. It's Australia, New Zealand, and Canada are attracting. I mean, the F3 years. It's the classic. They all escape, don't they, for a year or more. One of the major problems is actually trying to get back into the country. If you decide actually you want to come back to the UK to work, how difficult does our country make it for them to come back? Which is absolutely ridiculous. Apart from anything, particularly if they're a medical relationship. And they're in different specialties, so they have to apply to national schemes, and there's no way of ensuring that they're going to be together in the country. So I think there is an issue there. We recognise that people are leaving the country, but there must be a way of encouraging them back and making it easier for them.
But this is all about retention again, you know, and up until now, NHSE has had a complete blind spot when it comes to retention. And in fact, the reason why I wanted to talk to Stephen Kinnock without them in the room was at the previous meeting, I had 3 NHSE ladies, senior NHSE ladies, sitting in a row who were there specifically to stop me talking about retention. It was really a little bit like Macbeth, I would say.
All right.
The shift towards prevention, in the most recent BMJ, there's a couple of articles talking about moving it away from GPs. I just wondered what you thought of that and how that might impact on the profession, whether it seems a good thing in one way and not in another.
I think at the moment we've got so much work on our hands, it is very difficult to try and give more to GPs to do. But it does fill me with dismay, the thought that prevention should be taken from GPs, because I think that, you know, we have a very privileged position in communities as trusted members of the community. So, you know, when talking about vaccination, for example, immunisations being taken away. And again, as a college, we've written about this before, and we're going to write about it again, that we feel that needs to be dealt with extremely carefully. Because, you know, there's so much more we could do in prevention. And there are so many GPs, there'll be some of you here who are into lifestyle medicine, greener health, social prescribing. There's just so much more that we can do, and coming through the GP practice is the way to do it, really. It's the way to
Hi, I'm a junior doctor and I'm wanting to get into GP training, but it's been more difficult than I was expecting. I've tried one time already, but I didn't get in. There was 6,000 doctors applying in 500 places. And also with this talk about qualified GPs not having jobs, I guess like I'm looking to apply for the second time, but I mean, I need to really put my all into retaking this exam again. And just in terms of the retention issue, I've got lots of friends who have, well, quite a few friends who have gone to Australia and New Zealand, and others who are considering going. And it's not just because of the conditions, it's because they can't get a job or get onto the training scheme, which I think is something which is often missed out when we're talking about people leaving to these other countries. I guess maybe I'm asking for a bit of inspiration, or why you think I should really give it my all to try to get into general practice when actually it's looking quite difficult for me to get in.
Well, it is a fabulous job if you have the time and resource to do it properly. It really is. So please try again, and I'm sure you'll get there. I think that certainly government is starting to realise about these blocks in training pathways. It's not just for general practice, it's in other specialties as well, and is starting to realise that they need to wake up and do something about it, possibly starting with the foundation years first, but then with the other, you know, higher up training. Certainly the resident doctors are also very agitating. They're agitating hard about this because they feel very hard done by, I think quite rightly so. Yeah, I would say please keep trying. I hate to sound like a dinosaur, but in my time, it was difficult to get into GP training schemes. It was really competitive. These things are a bit like the tide, you know, they come and they go. And I hope that the tide will be in your favour next time and let you get in. Marcus.
Kamila, thank you so much for coming. Thank you for your eloquence and leadership. A really incisive lecture. We're all here because we're passionate about medicine in Nottinghamshire. I think that is certain, everyone in this room. As I drove here tonight, I call the 6 o'clock news, Radio 4, possibly the best news that there ever is. And within 15 minutes, there were 2 stories. The first was that NUH had been fined £5.6 million for 3 perinatal deaths. That had been reduced to 1.6 million because they're broke and also because they'd admitted liability immediately. And then the second story was that there was going to be a judicial review, a public inquiry led by a judge, which is going to report quickly on the Valdo Calacane murders. And all of that is in the city where we trained, where we work. It's on our doorstep. And it's world news, and it's shocking and appalling. What on earth is going wrong, in your opinion?
Goodness. Well, I think it's happening in lots of places. It's just that Nottingham's got it at the moment. You know, there are reviews happening in Wales as well, again to do with obs and gynae and patient care. It is a sad indictment, I think, of our NHS and the way in which our NHS is managed and run. And that needs to change. And from the little that I've gleaned from Wes's speeches, he intends to change it. He intends to reward those ICBs that are doing well. Obviously, he needs to have the right metrics to measure. But if he's got those, he's going to reward them, and he's going to make sure that the people who are not doing well get removed from position and get replaced. And he's already sending teams of surgeons from parts of the country that have actually managed their electives waiting lists better to parts of the countries where their elective waiting lists are not being managed better in order to help them change.
What I'm hearing from all of these questions really is that NHS England, obviously they're all Welsh, Northern Irish and Scottish bits, but NHS England isn't fit for purpose. The model that has evolved, which is massively bureaucratic, overmanaged, under clinically led, certainly under doctor led, is a fiasco. And most of us are working in that fiasco, and that absolutely has to change.
And again, you could see from what Wes is saying that he thinks the same. He's saying it in political speak, of course, but he thinks the same. He's asking NHS England to massively reduce its resources and its workforce. He won't accept poor management, and he's going to make sure that people who are not doing their job right get moved on, get moved away.
But to rethink so that young doctors can come back from New Zealand, Australia and Canada and Southern Ireland and work easily, so that established doctors, older doctors do not feel that after 10, 20, 30 years that they've collected so many bullets, scars and wounds that they can't function any longer, to decimate QOF just to the very basics of good patient care. There are absolutely massive kind of big changes to connect System 1 across the whole of the healthcare system, so that you can arrive in A&E and they can see what your GP did to you yesterday and work out what your GP should do tomorrow. There are some kind of no-brainers, really.
Absolutely. I couldn't agree more. And in fact, you know, that is what I said to Stephen Kinnock, is that it's all very well Wes saying that, you are on first name terms, it's all very well for Wes Streeting to say that there should be no resource without reform, but the NHS England needs to reform. It's no good looking further down the tree. It's got to start up there. And leadership should start from the top, shouldn't it? Yeah.
Our final question, David?
Thank you, Marcus. Camilla, thanks very much for your speech. It was excellent. I was rather dismayed, though, with some of the statistics that you presented about the lack of desire of young doctors to go into partnerships. You also have the statistic that general practice has been the most cost-effective form of health care delivery in the past few years, and I personally think that that may be because partnerships and ownership of partnerships and the care in primary care was a model that worked. It had its problems, and we all know what those problems are, and you've alluded to those. But could you give us an insight into what you believe is going to be the model or models of delivery of primary care and general practice in particular in the coming years?
I knew you'd come up with a killer question, David. So I think that we should be looking at a model of general practice that probably has to be flexible, because different parts of the country need to operate in different ways. And it needs to look like a practice partnership, but not necessarily be the traditional practice partnership with all the financial risk, the bureaucratic extra workload, the HR stuff that, you know, we were saying earlier, nobody's been trained to do. And some people do it really well and some people do it really badly. So we need to be thinking about, you know, how can we find maybe a variety of different models that still keep that family doctor partnership appearance, at least, with people who then also are given flexibility, maybe given a budget to make sure that they can achieve what they need to achieve, but they don't have all this other stuff that's going on every time the toilet leaks or the roof is, you know, blown a hole in, that, you know, you've got to go and get it sorted out. I always remember, you know, when I was on call one night in Cardiff, the police rang me at 3 o'clock in the morning to say, you must come now because the travellers have been on the roof of your practice and they've stripped all the lead off. So off I go and find the police there, and they very kindly have coiled it all up onto the pavement. And the police see me coming, there you go, Doc, there's your lead, and off they go. And I'm standing there 3 in the morning with this lead, which I can't pick up because it's too heavy, you know, thinking, you know, this is not what I was trained to do. So, yeah, all of that needs to stop, really, doesn't it? And we need to find, I haven't got the absolute solution as to how it should be. I think it should look like a partnership, but not necessarily be the partnership that you and I grew up in.
The word is flexibility. Flexibility in everything. I think flexibility in specialty training as well. I think the problem is that with general practice training, it's very rigid now, in all specialty training, and it doesn't allow people to chop and change and try and perhaps be very experienced and then go into general practice at a later date.
It's a real shame because nothing is wasted. It's all useful.
Absolutely. Yeah. Anyway, I'm going to call on Margaret Jones, who's our provost of the VOT Faculty, to give a vote of thanks.
I think I speak very loudly.
People online.
Okay.
Oh.
There we go. Thank you very much, David. Well, Professor Hawthorne, Kamila, thank you for such a comprehensive review of the challenges that primary care faces. When you issued the manifesto last year, I think that was very innovative, and it would be absolutely fabulous if 4 of those proposals are achieved, so we can hope that happens. You mentioned walking the walk in your talk this evening, but you've certainly been walking along a tightrope, and you've probably got a guide, so you're sort of on the tightrope with one hand for balance and a guide in front of you. But I have to say, and I'm sure all the GPs in the room will agree with me, that under your leadership at the college, we feel in very good hands and feel that you've done, you know, a really first-class job in advocating for primary care. So congratulations on that. Thank you. Yeah. I'm older than you are because I'm retired. But 14 years ago, I thought the NHS had challenges, but it was in a fairly stable state. And I think it's very disappointing to see what has happened essentially in that 14 years. We have to hope that Wes Streeting continues his collaborative approach and delivers on the increased funding and the focus for community-based care, because we had quite a lot of community-based care that used to work pretty well, which we've now lost. So I think it's something that we all hope and strive for, and we wish you all the best in the endeavours, advocating on behalf of all of us as doctors and patients. So thank you.
Thank you.
No, before you go, just one little thing. I'm going to present you with a medal. So
Oh my goodness.
The memorial, Tony Mitchell Memorial.
How lovely. And I remember I was a medical SHO when he was Professor of Medicine. Yes, thank you.
Thank you.
Sorry.
Gopi.
Gopi is our chair of
I
the
know Gopi.
Trent Faculty.
So thank you. Sorry, I didn't speak to you properly before I came in. So I should have come in. I just wanted to just get you something to say thank you for doing what you've done so far. I've sat in a lot of meetings with you. Thank you.
That's my most favourite.
I just also wanted to. Sorry.
Thank you. Thank you.
Thank you. Thank you everyone for coming.